patients with flaccid facial paralysis, dynamic smile rehabilitation has become the gold standard of treatment, and a growing body of evidence is starting to reveal its effectiveness in non-flaccid facial paralysis as well. In cases where the distal facial nerve is not intact, or there is atrophy of the native facial muscles, transfer of tissue with functional muscle and nerve is needed to reanimate the smile. Unfortunately, the free muscle flaps commonly used to reanimate the smile in both flaccid and non-flaccid facial paralysis are not ideal. To start, gracilis, sternocleidomastoid, pectoralis minor, and latissimus dorsi transfers have historically been oriented for single vector contraction, pulling the oral commissure in a superolateral vector, which leads to oral commissure excursion but minimal upper lip elevation. In contrast, smiles associated with genuine positive emotion involve both oral commissure excursion and upper lip elevation with dental show. To achieve this in smile reanimation, a muscle flap must pull in at least 2 vectors. To this end, several multi-vector muscle flaps have been described in the literature, although they're generally bulky and require dissection to produce multiple vectors, dissection that runs the risk of denervating or devascularizing the muscle. In an effort to design a free flap for facial reanimation that creates a dual-vector smile without adding excess bulk to the face, we report our experience with the Sterno-Omohyoid flap and assess its effectiveness in producing a dual-vector smile in patients with both flaccid and non-flaccid facial paralysis. In our technique, the muscles were inset such that the sterno-hyoid was sutured between the modiolus of the oral commissure and the temporalis fascia, thereby replacing the zygomaticus major, and the omohyoid was anchored to the orbicularis oris of the upper lip and fixated to a titanium mini-plate along the infraorbital rim. For the vascular pedicle, the superior thyroid artery and vein were coapted either to the facial or superficial temporal vessels. For the nerves, we sewed the ends of the ansa cervicalis either to the masseteric nerve and a cross-face nerve graft that was placed at the time of flap inset, or to the masseteric nerve alone. Of the 5 patients identified for our study, 4 had flaccid facial paralysis, and 1 had non-flaccid. The average patient age was 39 years, and the etiologies of facial paralysis were 2 acoustic neuromas, 2 congenital, and 1 temporal bone fracture. 4 patients ultimately developed contraction of the flap, and 1 did not. Measured retrospectively using eFace and Emotrix software, our results were as follows. Mean oral commissure excursion postoperatively was 7.6 millimeters. Mean dental exposure was 2.9 millimeters. Dynamic, smile, and mid-face smile eFace improvements were 20.3, 25.5, and 50.5 points, respectively. The mean flap mass without debulking was 14 grams. Mean time to movement was 6 months. Median follow-up was 20 months. Operative time averaged 17.4 hours, with dual innervation cases at the longer end of that range. All patients denied any new difficulties with speech or swallowing after strap muscle transfer. So ultimately, the Sterno-Omohyoid flap was able to produce results comparable to gracilis-free muscle transfer in terms of improvements in oral commissure excursion and symmetry in patients with both flaccid and non-flaccid facial paralysis. But we also managed to improve dental show and add only minimal facial volume without the need for intramuscular dissection. That said, this is a small series, and more work needs to be done to refine techniques and outcomes, particularly with respect to the flap's somewhat inconsistent venous outflow.